Good morning and welcome to the Institute for Public Policy and Social Research's Legislative Staff Training. We're glad that you could join us. We're proud to put on this event in conjunction with Government Affairs and MSU Extension and with the support of the W.K. Kellogg Foundation. I'm Matt Grossman. I am the director of the Institute. And we know that COVID has upended all of our lives, but we also see an opportunity to talk about some broader issues that it has brought to the fore. So we're very pleased with the group of panels that we have for you today, and we hope you're able to stay with us. To guide us through them, I'd like to introduce IPPSR Associate Director Arnold Weinfeld, who is also at MSU's Office of Outreach and Engagement, and has put together today's program with help from those folks I just mentioned. Arnold, take it away.
Thank you, Matt. And again, welcome everyone to today's IPPSR Legislative Staff Training. As Matt noted, we've got a great lineup of speakers and presenters discussing various issues related to COVID. Just a couple of notes, attendees are muted. So if you have a question, please put it in the chat or Q&A box and I'll be moderating that. And we will get to questions as soon as we can, given time constraints as well. Other than that, I think we're ready to get going. So let me introduce the first session on telehealth. And our speakers and presenters are Dr. Jacky Prokop, who's Director of the Program Policy Division with the Michigan Department of Health and Human Services. Tim Nordhoek, Business Development Specialist with the Michigan Health Information Network. And to get us going, Mary Graham, who's Manager with the Michigan Health Information Network. Mary, why don't you get us started?
All right, let me share. Good morning, everyone, and thank you for joining. Let me get to the right screen. There we go. And put it in slideshow. There we go. There we are. All right. Thank you again for joining, and we're going to spend a few minutes talking about the Michigan Health Information Network, since the state of Michigan and MyHIN work very closely together, and it's important for everyone to understand, and because it's complex, it bears repeating, even if you are familiar with the work of the Michigan Health Information Network. Then we're going to pivot over to telehealth, and then talk about how telehealth and how we're responding to that relative to COVID. My partner, Tim Northuck, and I will be tag teaming. So you'll hear us both speaking. I will be driving the slides. And Arnold, can you confirm you can see my slides?
Yes, we can. Thank you.
All right, thank you. Then let's get going. The Michigan Health Information Network is, in fact, the state designated entity to continuously improve healthcare quality. And when we talk about that, I want you to think about the triple aim. And the triple aim is, of course, managing healthcare and improving cost, outcomes, and the patient experience. When we talk about when we reference the triple aim, of course, that is built on the platform of patient-centered medical home. And that is something that the state of Michigan has been working on for about 2 decades and done an awesome job. We are a leader in the United States relative to becoming patient-centered and having that whole transformation paradigm in place in order to manage care at the point of care and the time of service, but really make it PCP and patient-centered. When I say PCP, I mean the primary care physician or provider that you would regard as your family doc. Getting the information needed to the point of care at the time of service is obviously hard to do when you look at a slide like this. It should be impressive, but it also should be a little bit daunting because this information is needed by sources throughout the healthcare ecosystem, but it's also coming from all of these different resources and technologies and healthcare models and so forth. And so in order to organize, standardize, and normalize that data, that is the mission of the Michigan Health Information Network. Our job is to take all of that data from all those silos and technology formats that don't talk to each other and get them into a common pool, if you will, here at MyHen, and then deliver them back out. That's why the arrows go two ways. If you take nothing away from today's conversation, if you take away that MyHen is here to stabilize, standardize, and normalize data exchange in the state of Michigan, then this was worth it. How do we do that? We do it through a concept called the use cases. And the use cases are all the different ways that we work with that data. And there's all these different things that data is needed for. So there's admit discharge transfers, there's discharge notifications, there's immunizations, there's you might want to see healthcare over time in one spot, not in all the different places. There's referring from place to place. All of these are the use cases that we've been working on here at MyHen for at least the past 10 years. You can see we have conceptual models, planning and development, implementation, and mature. This is a recently updated slide because we're constantly progressing. We will look to our partners like the state of Michigan to help us finance and drive these efforts, and also the health plans. And then of course we work with all of the providers, helping them to come on board to these different use cases so that this data is readily available no matter where you show up. All right, so that's kind of MyHen in a nutshell. Now we're going to talk about telehealth, and I'm going to pass the ball to my colleague, Tim.
Good morning, everyone. Mary, can you confirm that you can hear me?
Mm-hmm.
Excellent. Okay. So when we talk about telehealth, there's obviously a lot of different ways we could think about what it is, but in layman's terms, it's basically just an electronic method to get access to some type of healthcare. As we've seen things progress, obviously with the pandemic that we're all experiencing right now, before the COVID-19 pandemic started, we saw a lot of in-person care as a standard, and telehealth was more of an option or an add-on. So it wasn't a lot of adoption across the board, and if there was any adoption, it was slow. The market was competitive, disorganized, and as soon as the pandemic started, we saw a rapid and broad adoption to meet the need and to get care to the patients that needed it. We also saw that the Office for Civil Rights relaxed HIPAA enforcement, which allowed for non-HIPAA compliant tools like FaceTime, Google, WhatsApp, just to get care to the people that needed it. So it almost increased the disorganization that we saw out in the market. As we're moving through COVID, telehealth is part of the new normal, and we're seeing somewhat of a trend to going back to in-office visits. Everyone has selected some type of telehealth method or vendor out there, and regulations remain less restrictive. But as we're looking forward, we believe that, as Mary had mentioned earlier, working towards getting telehealth embedded in the patient-centered medical home, we'll see that the reinforcement of the HIPAA compliant modalities, and providers are looking for more than just a telehealth solution. So not just some type of virtual healthcare method, but also looking for some type of integration with health information exchange, electronic health records, which will help enable some type of patient self-management. So you'll see that over time, we anticipate the consumer value will increase as healthcare delivery evolves. Next slide, please. So as we mentioned, there's various levels of telehealth solutions. There's going to be the non-HIPAA compliant solutions like the FaceTime, Facebook, WhatsApp, which were used somewhat in more of an emergency method and are not going to be around for long term. There are other HIPAA compliant national providers that provide healthcare, but the care is outsourced and it's not going to be with the primary care physician. So, for example, my mother did this type of solution and was confused when she was connected with a doctor that was not part of her network. Obviously, this could cause some disruption because the information that was resulted from the meeting may not necessarily get back to her primary care physician, and it's not more or less ideal. There are other HIPAA compliant virtual meeting rooms like the DoxyMe, Blue Jeans UpDocs, where the provider can initiate a visit, but not necessarily the patient. So this puts the onus back on the provider to manage the visit, but the patient can't necessarily schedule something with their provider. So it's still not ideal. There are HIPAA compliant telehealth platforms out there like the CareConvene, Amwell MD Live, which the patient can initiate the visit. They download the application, schedule a visit, and everything's done through an application. This is still not the ideal situation, but it is a very nice, convenient way to connect the patient with their provider. And then lastly, we have a HIPAA compliant integrated health information exchange health platform where we have CareConvene, which is integrated with the Health Information Exchange, i.e. MyHIN, and that's where we can maintain the continuity and medical home relationships, and the information that is captured during the telehealth visit is sent to the Health Information Exchange and documented, so we have record of that, and it allows for the patient to manage their self-care. Next slide, please. Okay.
So how do we normalize that? If you have that much variation out there, some of the providers are actually delivering their own telehealth. Some are using back-end contractors or vendors like Tim just went through. Others are in fact only, they're not using the vendors as backfill, they're using them entirely. And then you have actually health plans offering their own telehealth because of their need in order to redirect traffic away from urgent cares and ERs and get appropriate care for non-acute, non-urgent, non-catastrophic kinds of healthcare. People shouldn't be going to the ER during times of COVID if they can be treated in other ways. So telehealth comes in as an option, and it's a very viable option. And as Tim said, pre-COVID, 90% of healthcare was probably in person. During COVID, it actually flipped to 90% was around, we were seeing data that 90% was being delivered virtually. Now it's tapered back down. I think Jacky's going to talk about that and what she's seeing at the state, but also the idea that, it's not going away now because people understand it, they've used it, they like it, and so do the physicians. What is MyHIN's role for this? Well, our use case is to not tell people what to use, but to make that information available and to integrate it into various resources. So if telehealth can support things like care coordination, patient engagement, and the use cases that we looked at briefly earlier on, what would be our approach to normalizing and standardizing that? Well, it would be making the information available. We were getting feedback during COVID that one family that we talked to, 3 members of the family, each of them had 3 docs. That was 9 different telehealth platforms that they had to manage and understand. And as Tim's example with his mom was talking about, it's sort of like, okay, there's a lot of crazy out there and there's a lot of variation. How can we help with that without dictating what needs to happen? Well, a telehealth registry will do it. So as the providers get a telehealth service, we will step in, they can share that information with us, and we can display access to the telehealth service of each provider at the health plans. So the health plans are talking to us about the opportunity to display that as a member resource within their member portals. And that plus the opportunity to display that within our own resources is in fact the telehealth registry. So we're fitting in a really interesting little place in the middle that wasn't really part of the ecosystem before. So we're creating that. Then in the telehealth registry, and what we're showing here is the member experiences on the left side. And that would be where the member logs into a telehealth portal and they actually navigate, typo, to the telehealth page. And then they would wouldn't select the vendor. They would be selecting Dr. PCP and Dr. Specialist and Behavioral Health Center. And these would be their physicians, their providers as known by the actual health plan. And they could click a link and go right to that provider's telehealth page. So that would be the member experience. And we describe it further on there. We're also showing you, and I want to make it clear that we are vendor agnostic, but we do offer solutions ourselves for those people that are looking for the ones that work directly with us and help activate all those use cases. And if they just are looking for a service that they want, they can get it from a source they trust. So one additional note that we wanted to spend a minute talking about, those of you that were familiar with Great Lakes Health Connect, actually I used to work there. That was part of an HIE that was very robust and did a lot of work in the first 10 years statewide, really working at the provider level and working with the communities to stand up solutions they needed, while Myhin was out doing the use case work. In order to make sure that we could present and provide the most unified and robust solutions to the state of Michigan. So use cases, services, and solutions, or tools, if you will. What you see on the right is all the different ways that we can help the state of Michigan in addition to the use cases. And Tim, I'm seeing that my connection is unstable, so you may have to jump in. Can it?
Okay.
All right, good. You can still hear me. Excellent. This is CareConvene. And Tim, did you want to talk about this, or do you want me to keep driving?
I can jump in. Yep,
okay.
Sounds good. All right, so about a year and a half ago, Myhin partnered with a company out there called CareConvene. They're a patient and provider-focused telehealth platform that's easy to use, and we are actually its exclusive reseller. CareConvene is more than just some type of virtual meeting room, but it's more of like a platform that will leverage health information exchange like Myhin and related technologies to co-manage illnesses, coordinate care, and work through the challenges that we're facing. So CareConvene offers 4 different solutions. CareConvene Plus is kind of that virtual practice where it offers patient self-management tools and on-demand and scheduled visits. Also allows for care management coordination and social determinants of health reporting. CareConvene Integrated takes it a step further with the actual integration with the health information exchange, which allows us to use real-time admission, discharge, transfer, CCDA, and chronic issues reporting into the application. It's also EMR interoperable and allows us to use APIs and Amazon Fire integrations. So CareConvene Plus allows us to push out a visit through a text visit. So if the patient wants to connect with their provider, they complete a form through the application, and the visit information is pushed out to the patient with a text message. All the patient needs to do is click on that text link, and it will connect them with their provider. Also, it provides some type of full application integration or experience through CareConvene. We also have a CareConvene Screen, which is similar to some type of in-person form that is completed by an employee or a student, where they attest that they are not experiencing any type of symptoms from, let's say, COVID. But this is all done through an application. It can be done whenever the patient or the employee wants to have it completed. So they don't necessarily have to do it in person, and it just allows them to complete a questionnaire whether or not they are experiencing any symptoms. It also allows for very easy HR reporting through the application without any type of managing the physical paperwork. It's all done in the application. And you'll see that there's a screenshot in the middle of the slide here sampling the coronavirus screening what that looked like. And then lastly, we were working on CareConvene Consult. It is not currently live, but it's being built. And this is a 3-way televisit, which is where we can merge calls with a guardian or family member with the primary patient, or we can also have a primary care physician bring in a specialist to consult over the patient in one single visit with the patient. Next slide, please. Okay, this slide's pretty simple and straightforward. Basically, on the left, you have an example of what the phone application would look like. And then on the right-hand side, we have a web or laptop version through the web browser. Next slide, please. And continuing on with like that CareConvene screen solution we talked about earlier, you can complete some type of questionnaire as to the reason for the visit. And if someone was to click on the coronavirus screening in the bottom right-hand corner of the application, it'll route the patient through the screening questionnaire on the right-hand side. Next slide, please. Okay.
Yep.
Mary, any other comments, questions?
If, again, want to make clear that our mission and our passion is to get the needed information to the point of care at the time of service. And we have certainly been assisting the state of Michigan and the city of Detroit during COVID with those needed labs. When we were speaking specifically to telehealth and COVID, two things, obviously, that we're finding a place that we can contribute to our mission and passion for really normalizing and standardizing some of the work that happens with telehealth and some of the variation to make a better patient experience and to drive down costs and, of course, better outcomes. The final thing that I'd like to say, of course, is that this solution to telehealth is really supporting the patient-centered medical home. One of the things I talked about very briefly was the idea that health plans stand up, and actually I contributed to that when I worked at Priority Health, stand up a healthcare service that's usually vendor-based. And that is, in Tim's example, it lures the patient or it serves the patient away from their primary care. That's not ideal. And it means that dollars are going from health plans to vendors as opposed to the primary care. Everybody wins if the primary care starts doing telehealth in whatever fashion, because the patient wins, they get to see their primary care or their affiliated practice providers at that practice. The health plan wins because people are not going to the ERs and urgent cares unnecessarily. And the state wins because we've normalized and really organized care back at the patient-centered medical home, which is ideal. Dollars are going to the right places for the right care at the right time with the right providers and the patient. So telehealth is a great solution if we do it right. And that's it for me.
Yep. Thank you, Mary and Tim. Great presentation. I don't see any questions yet, but I've got one that popped into my head, and I'll frame it up this way. There's a commercial right now for a new Apple Watch that a person can wear and, give that person all kinds of medical information directly. And my first thought is, that's great. How come we don't make that available to everyone? So my question to you is, this is great, but what are the discussions regarding equity? Not everyone has a smartphone or a computer connection. How do we make sure that this option, which I think is a great option, especially during COVID, and I think it's going to be one that certainly benefits folks moving forward, how do we make sure that it's as available to as many people as possible, despite the barriers that might be in place?
That's a great question, Arnold. I'll take first pass, and I do apologize. I have to drop for another meeting, of course. So my response to that is, you have the right audience to be asking that question, and we may not be the best respondents. The folks that work within the state legislature and in organizing the work of our public office are the right folks to be answering that question. One of the things with telehealth that we've we've identified as a benefit is that actually most people either have a phone or can share a phone. And it does have to be a smartphone, but that actually contributes to the experience of the patient. In other words, if you want to just drop to regular talking, you can do that. If you want a video experience, then you have to have the right operating system, and you have to have the connectivity, if you will, you have to have the service to make that happen. That's a problem in rural. So making sure our rural communities have internet is an ongoing challenge that telehealth and my hand can't solve. That's going to be other resources. And I hope they do. And then the second piece is the urban or the socioeconomic challenges of certain populations that simply don't have access to a phone at all. Well, they probably have they have many other issues as well. So yes, this telehealth is a great resource, but it faces the same challenges as many of our other resources. It can address, however, and I neglected to talk about this, it can address access, which is a barrier. When people don't feel safe to go out because of the healthcare condition, the pandemic, or because of other safety issues in urban society sometimes, or they just can't get out because of weather, access, or there's nobody serving in this particular area. Telehealth can address the access issues. So telehealth is the right fit for many problems, but it is not going to solve the basic problem. And that was kind of a long answer, but I hope that helped.
I think that's very helpful. Thank you very much. Tim, anything you want to add to that?
Sorry, I was on mute. No, I
Okay.
think Mary answered that perfectly.
Super. Thank you both very much. Now we'll turn to Jacky Prokop of the Michigan Department of Health and Human Services. And let's see.
Hi, good morning. So I think Arnold's going to be displaying the slides for me.
There we go.
For some reason, I have problems with Zoom and being able to put it in a PowerPoint presentation mode and advance my slides. So this will work, we'll partner. So again, I'm Jacky Prokop. I'm with the Program Policy Division in Medicaid. So we oversee the promulgation of the Medicaid policies that you all may receive during our public comment and final. Next slide, please. And thank you, by the way, for allowing me to speak today. Telemedicine is something that we have, it has been at the forefront of our policies in regards to COVID-19. And we're still very much involved in really looking at what telemedicine is going to look like going forward. So just a quick recap, you know, I have about, I think 20 minutes or so to do a presentation, and really this presentation I could stretch out for over an hour, but I wanted to touch on some very important points for this audience of things that we've been working through. So I'm going to do a quick overview of telemedicine in the Medicaid program, give you a feel for the policy bulletins that we have put out already, promulgated. I do have some telemedicine utilization data that I'd like to share. And then I also want to touch on some of the bills that have been passed in regards to directing the Medicaid program to cover telemedicine, and to give you an update as to where we are with that, and then talk about next steps. So next slide, please. So with this slide, I always had learned in writing a PowerPoint presentation or putting one together, you're not supposed to put a lot of words on the slide. So I completely have violated that here. But what I want to communicate in this information is that with a Medicaid program, we are very careful in how we define a number of things like medical guidelines. And when it comes to telemedicine, there's already a definition that's in the insurance code and was recently updated. So I just wanted to, you know, confirm that this is the definition that we also go with. I think it's very important to make sure everyone's on the same page and looking at the same language in regards to telemedicine. Another thing we need to make sure with telemedicine is that we are following the HIPAA protocols and that we are compliant with HIPAA. And when we put out policies related to telemedicine, or I'm also going to use the term telehealth, one of the things that we did which is different with COVID-19, is that we allow for a telephone only visit. That was something that, as directed by the federal government, that we could waive any of the HIPAA requirements around doing this type of a visit. And so we allowed that for COVID, as the federal government said we could. And that's something that, again, once we go forward, I think that that's going to be pulled back. We're not going to have that flexibility going forward. Another thing that we were very focused on too was making sure that there was beneficiary consent for a telemedicine visit and that there was a contingency plan that was established and maintained. What I mean by that is if somebody goes in to see their doctor and they're obviously in distress, medical distress, the doctor at that point could say, you need to go right to the ER. And so if they're doing a telemedicine visit and they're picking up on those things, they need to be ready to direct that patient as to what they need to do. Next slide, please. With this slide, I wanted to give you a flavor of just how far-reaching that telemedicine can be in terms of the different types of providers that were impacted by this. I mean, when I think of telemedicine or I hear presentations, I know they really focus on office visits with providers, but it goes far beyond that for what we had looked at for Medicaid in regards to like even inpatient consultations. A big thing is with behavioral health. We had a lot of telemedicine visits once we opened it up and allowed them to begin providing these visits. I'm not going to read through all of them, but this gives you a feel of just the different types of areas that can be impacted by telemedicine. And there's a note on the bottom of the slide that talks about a database. So as we were putting out all these policies, we wanted to make sure that it was clear to the providers just what type of services could be billed. So we actually created our own telemedicine database and directed providers and said, if you're curious as to what you can do in this format, here's all the codes and a description of services. So we got that up right away as soon as we possibly could once COVID-19 hit. Next slide, please. So a brief overview of the number of policies that we put out. And you'll see that there's a reference of MSA 2009. That's the first one. If you're looking for any of these policies, when you go to our website where we have them all listed, this is what you would look for. But, with 2009, excuse me, that's actually what we call more of a permanent policy. That was something that we were already in the process of moving through the promulgation process. And actually, it was slated to start June 1st of 2020. But in the middle of March, when COVID-19 really hit, it was actually out for public comment. And what we did is we pulled it back and we issued it for a dual public and final. It was a policy we had thoroughly vetted and we knew we needed to go forward with. And so with COVID-19 and getting this information out there and understanding that beneficiaries were not comfortable with going to see their provider in a face-to-face format. And also we all know that a number of things were sort of shut down or put on hold in regards to businesses and interactions. So this was something that we put up right away. The next one, this talks about MSA 2034 talks about, it's with our federally qualified health centers and tribal health centers and rural health centers. It talks about how we pay them and that we didn't have any state plan authority to pay them just for the telephone only visits, although we do have it now. But we did it prior to COVID. So we wanted to communicate to the tribal health centers and the centers that if they did a telemedicine visit where it was either audio and visual, or if it was audio only, that this would be covered and they could receive their reimbursement rate for that. And then 2013 talked about allowing audio only. The regulations were coming at us pretty fast and furious and we were keeping up with them. So when the regulations came out that said you could do audio only, that's when we converted to that and we put out a policy. Next slide, please. So continuing on the theme, MSA 2022 allows for different types of therapies, PT, OT, and speech therapy to be performed. And here we said it had to be audio and visual. Now, please keep in mind, not all of the visits that this particular provider these provider types can do have been converted to a telemedicine format. But what we did is we looked at what services they could provide and identified by code and service what it is that we would allow in a telemedicine format. MSA 2021 speaks to dental services. We only activated one code for the providers. And this is if somebody had a really bad toothache or had an issue that they could call their dentist and they could talk about it. I think it's pretty obvious they couldn't have teeth cleaning or any other procedures done. There's limits, of course, with telemedicine, but this allows them at least to interact with a dentist. And hopefully that prevented some ER visits because the dentist at that point could decide if there was like an impacted tooth or there was an infection, that perhaps they could treat it in that manner. MSA 2042, it talks about the reimbursement for telemedicine services. And when we pay providers, there can be two different rates for office visits. And we use the term facility and non-facility rate, and it's confusing, but I'll try to explain it simply. This is kind of the world we live in. So it's how we determine how rates are paid. But if somebody is if a provider is in their office, they have to pay the overhead and those types of things, the building, et cetera. So that's considered a non-facility rate, and that tends to be the higher rate. And then there's a facility rate where maybe they go to the hospital, they go to an outpatient setting, and they perform their services. They get the facility rate. So this policy just kind of talks about what rates we're paying for telemedicine visits. Next slide, please. So this is something that we've been tracking, and this is telemedicine visits that were performed. And to introduce this slide, we started it from January and it goes to August of 2020. And the blue line, of course, hopefully everyone can see this very well, that's unique telemedicine visits. The orange line is the total number of beneficiaries, distinct beneficiaries who had a visit. So, in general, this shows that it really peaked around April of about 250,000 telemedicine visits for that month. And you could see a clear pattern that in January and February, we already had some telemedicine visits already in place. But of course, you can see in March when we greatly expanded and we started sending out our policy bulletins, that the utilization just really took off. And it is interesting to see how it is tapering down. I also, I want to, put some caution with the July and August numbers. This information comes from paid claims data. So there is some, claim lag issues, meaning providers really have up to a year to bill for services, but a very high percentage of them bill within the first 30 to 60 days. So, if we keep running the data, July and August numbers might go up, but I think we're definitely at this point seeing a trend that it's going down. And to me, I think what this says is that people that needed to have access to care still were able to connect with their providers. And one thing that we're trying to learn and going forward is, how open do we continue to have telemedicine visits? Does there need to be more guardrails, so to speak? And we're kind of working through those details. I know that in talking to other states and other Medicaid programs, we're all asking the same questions. We all really opened up telemedicine as I believe is appropriate, and then figuring out what this should look like going forward. And I'll speak of that a little bit more in my presentation. Next slide, please. I like to show this information. It gives providers, to give you a flavor of what providers are billing for services. So we know what beneficiary utilization is. And again, I'm not going to go through the whole list, but I wanted to highlight a few that, the top two are really your internal and family medicine. These are physician visits. And then you have social worker visits, which may speak more to mental health related issues. And then the FQHCs really are also typically physician visits, but they provide a mixture of different types of services. The one area I wanted to highlight of how telemedicine and COVID-19 really kind of changed how we provided services is the maternal infant health program is a good example of that. That's the fourth from the bottom. Prior to COVID, we always said that we wanted the providers to be seeing the beneficiaries and to go to their home or have face-to-face visits. Now the maternal infant health program is a service. This is something that nurses and social workers provide services to pregnant women and to children within the first year of their life. And, it's an education, it's connecting them with social supports and making sure that they have what they need. And we always felt strongly there needed to be face-to-face visits. Well, when COVID hit, a number of pregnant women or new moms were uncomfortable with having someone come to their home for the concern of having a COVID exposure. And so we did convert it to a telemedicine visits. And this is something where I think we're going to retain some of this, but we still value and we really think that there needs to be that face-to-face visit. So we're working through some of those things. But I hope this gives people a good feel for who has billed for telemedicine visits. Next slide, please. Oh, my slides bounce around. So the previous slide where I showed you telemedicine visits was primarily physical health. There is some mental health, but it represented Medicaid fee-for-service, the health plans, the ICOs. What this slide represents is primarily data from our PIHPs, and it's really focused on moderate to severe mental illness. And the light green bars show that, visits that were more specific to mental health related services. And the dark blue is more specific to substance use disorder services. And I think it's very interesting to see too, there's a similar pattern here with how the numbers just shot right up. But also a good thing in that, that there were a lot of visits that were provided. I hope you can see the numbers, but when you look at the June numbers, there were 464,000 visits provided for mental health. And I think that's very important. I think this is very important data to see just how much access was provided using telemedicine. And this is an area when we think about going forward, what are the policies going to look like? So I just thought that would be interesting for people to see what the numbers were showing. Next slide, please. I thought this was also an interesting thing too, because we're starting to look at our populations and who's receiving services, and we are doing more data analytics, and we'll have more data here in the very short term. But we're starting to look at who's using the telemedicine by geographic area, age, race, and for today I had the age information available. We're working on the others and doing other comparisons, but I want to just communicate to this group that we are looking at this because we're also concerned about disparities. And how that may impact individuals, and what sort of things we may need to do to help remedy any issues that we find. But with this, you can see at the bottom of the screen the age ranges, which the first bar, of course, is 0 to 4. And to me, what this says is it has the total number of visits by age. That it looks like a lot of by the age group, that a number of these age groups had 20 to 25,000 visits. I'm sure people notice that when you get to 65 and older, that it just drops right off. I want to put caution to that data as well, because as a reminder, people become Medicare eligible. So Medicare would be the primary payer. This is Medicaid data. And so we may not even see those claims. And so probably what's happening here is these are some of the crossover claims that we're seeing, but there's more activity being provided in these age groups that we wouldn't have the claims data for. So anyway, next slide. So what I wanted to highlight here is there were a number of bills that were passed, and the numbers are there, the House bill like 5414, and there's a brief summary of each of them in terms of their recommendation going forward or what we are required to do in regards to covering telemedicine visits. And I just wanted to highlight them and to indicate that through our policies, we are compliant with these. Next slide, please. And same is true for the other House bills that were passed. And again, there's a brief description of remote patient monitoring services. And just as a highlight, we do cover remote patient monitoring services. And as new technology comes out on the market, we look at it. We look at it primarily for efficacy and to see if this is something that should be covered, and we make those decisions on a case-by-case basis. I know there was a question that was brought up regarding the use of an Apple Watch and whether or not we would cover that. We would have to look at, we have to make sure that it's ordered by a provider, and this is something that a licensed individual would require a patient to need. But again, we have requests that come in for different types of, I guess I would call this more telehealth activity, and we do activate codes as appropriate. We work with our medical department, our physicians, our Office of Medical Affairs to make those decisions. And then House Bill 5416, it talks about covering home as a site for a beneficiary, and we are also compliant with that as well. Our policies do allow this. Next slide, please. So when we wrote a number of policies expanding telemedicine services, we did that with the theme of they won't be able to have a face-to-face visit, or they're concerned about meeting with their provider face-to-face in light of COVID-19. So the things that we're thinking about right now is, at some point the public health emergency will end, and we need to take a look at what our policy should look like going forward. The federal public health emergency has been extended. I believe it ends in January now. They recently extended it from the end of October. But I wanted to give people a flavor of some of the guiding principles and some of the things that is influencing our thinking and going forward. Just making sure that beneficiary privacy and security is established and maintained. We're also looking at the effectiveness of the service for beneficiaries. You know, there may be a situation, excuse me, where perhaps like in a mental health situation that a beneficiary is interacting with their provider on a weekly basis through telemedicine. You know, in going forward, is this the best thing? Should there be face-to-face visits, or should there be a ratio of how many telemedicine visits to face-to-face visits, or vice versa? And these are the questions that we are asking ourselves right now. And you know, I can honestly say other states, other insurers they're struggling with this too. And I think in going forward, this is something we're really going to need to have stakeholder input in terms of deciding what this is going to look like. And we have heard anecdotally from some of the CMHs and from some of the mental health community that they do believe that there should be guardrails on this, and that it shouldn't just be, you know, do as many telemedicine visits as you want after the public health emergency ends. So I just want to communicate that we are looking at that. Maintaining appropriate access, right visit for the right beneficiary. You know, telemedicine visits are wonderful, but they can't always do everything that can be accomplished in a face-to-face setting. You know, one of the issues that we have is like with children and going in for their well child visits. You know, they can't get immunizations through telemedicine. They can't look at height and weight. So there's a number of things that we still need to address. Ensuring providers are utilizing telemedicine appropriately. And it gets back to the effectiveness of services for beneficiaries. And then we have value considerations if we're getting good healthcare outcomes from this. So these are some of the things that are really influencing our thinking. Good timing. I'm going to the next slide. So again, Medicaid is looking through this, and we have had a group that has met internally, and we are coming up with what we propose things should look like, and we're going to begin. We actually are in the process of doing some stakeholder engagement to get more feedback in terms of what we are going to propose going forward. Next slide, please. So that is my contact information, and that ends my presentation. But I welcome any comments. If people have any questions, I'm glad to answer them.
Thank you, Jacky. I appreciate the presentation and the work that you're doing. We have at least one question for you or Tim. I don't know if Mary's still with us, but there's legislation currently being discussed in the legislature, Senate Bill 898, that would require reimbursement rates from health insurers for telehealth services to be the same as the reimbursement rate for in-person visits. From a broad perspective, the question asks, should there be a standard reimbursement regardless of whether the service is provided in person or through telehealth?
Great question. We've been looking at this as well. Right now, we do pay the same as a face-to-face visit would be. That goes back to, I was talking a little bit about facility rate versus non-facility rate, which is, I understand that's a bit confusing. We tend to follow in Medicaid, we tend to follow Medicare guidelines, and Medicare did pay, there are two rates, the lower of the two, but with COVID-19, Medicare is paying the higher rate. And so right now we are having discussions about that. And if Medicare goes down, we'd more than likely follow their lead on that. But we certainly welcome any comments in terms of how we should approach this going forward.
Great. Tim, any thoughts on that?
It's an excellent question and something we've all been considering in light of the pandemic. I would say personally, I would see that, yes, they should match in-person office visit rates because, again, there are some negatives, as Jacky addressed, that, you know, there's things that they can't do with a virtual visit that they can only accomplish with an in-person visit. However, the patient's still receiving care, the same care that they would if they were in office. In addition, it also incentivizes the patient to not be in person. And during the pandemic, you know, it's going to help reduce any type of readmission with hopefully not COVID, but any type of other symptoms, excuse me. And, it also, it keeps people out of the emergency department or urgent care to get, basic needs met. So I would say yes, but somewhat of a outside perspective.
Sure. I think, this was, Jacky, you touched on this in one of the last slides, but I'm gathering you both expect telehealth care to continue post-COVID. Yeah.
Yeah, I would say that that's a true statement. COVID certainly allowed us to, it really expanded a lot of the telehealth services that we provide. Without COVID, we would not have opened up these codes as we have. And I would argue that post-COVID, we do need to reduce it. But, still, it begs the question of exactly what this should look like. And, like I said, it starts with us in policy saying, here's what we propose, but we really are going to need to have input from others, because I think, a lot of times when we do policy, we can do research, there's studies, there's a lot of information out there about what works best. And with this one, there's not a lot of data out there. So we really need to carefully think through this and make sure we're getting the correct stakeholder input. And, going back to the rates, this is something that, again, we haven't fully landed on something. We're still talking about it, but the office visit rates that we pay are to pay for a number of things. Obviously the provider's time, but it's also other administrative fees of having an office and those types of things. And so with telemedicine, you could argue with those visits, there may not be as much overhead, but yet we've also heard that it takes a fair amount of funding for the providers to set up a telemedicine platform. So there's a lot of things that are connected here that we still need to work through.
Tim?
Jacky, that was an excellent response. I would only maybe add that, we are seeing a trend to going back to in-office visits, but I think that's partially to do with, one, I think people are getting a little more comfortable with, where things are at with the pandemic, and then two, maybe partially due to funding and incentives of where, I guess the provider is going to be, incentivized to go one direction or the other. So if we want to continue to incentivize the provider to offer telehealth services, we have to make sure that the dollars are there in order to lead them that direction. Otherwise, we're going to see probably a push to maintain, normalized business in the office.
Yeah, I think there's also a third piece there, and that is that human beings are social beings, right? And so, the best interaction for them is one-on-one. And so, well, I do think telehealth, COVID has shown the benefits of telehealth, especially for those that are homebound or, for one reason or another, unable to get to a doctor's office personally, or certainly to keep track, provide status if someone is under critical care or constant care of some kind. I think telehealth certainly, we've seen the rise of telehealth, and I think it's here to stay and can be of great benefit. Again, I think we have to solve that equity issue at some point. And you're right, and Mary was right too. That's beyond a bit of the scope of what you all provide, but certainly from a policy perspective, letting lawmakers, letting policymakers, letting the decision makers know what the impediments, what the barriers are, will help to give everyone a better experience. I think that's about all we have and all we have time for. I want to thank Mary Graham and Tim Nordhook from MyHin, Jacky Prokop from the department. Thank you to all of our attendees. We're going to take about a 10-minute break, and we'll be back at 10:40 with our next session, a professional development session specifically targeted at staff regarding working from home. So thank you again to our presenters, and we'll be back shortly.